one landmark trial, endovascular thrombectomy with or without intravenous alteplase in acute stroke. My name is Dr. Bhushan Kurade, MBBS physician. You can follow me on Instagram, Talk by Dr. Bhushan. Talk by Dr. Bhushan.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of some whatever. Under any circumstances, the author accept no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
Clinical question: patient with acute anterior ischemic stroke is endovascular thrombectomy alone compared with the endovascular thrombectomy preceded by the intravenous alteplase non-inferior with respect to the modified ranking score at a 90 days. Background for this study: this is a trial study where established the role of endovascular thrombectomy in treatment of eligible patients with acute ischemic stroke. These are the trial which explained in our channel playlist. MR Clean Extended 1, AI Escape, Sweep Prime, Reboss trial. In further videos, we can describe or explain this trial. The role of alteplase because the during thrombectomy in patients with ischemic stroke is unclear. It may improve the reperfusion potential, dissolve distal thrombi, but not make a proximal thrombi more difficult to retrieve with the thrombectomy. It may increase the cerebral hemorrhagic rates. Designed for the study, the investigator initiated the multi-center prospective randomized open-label trial with blinded outcome assessment, direct intra-arterial thrombectomy in order to revascular acute ischemic stroke patient with a large vessel occlusion efficiently in Chinese tertiary hospital, multi-center randomized control trial funded by National Health Commission of China, VGME, Jiping Medical Foundation. No involvement in trial design, conduct protocol, zero manuscript to patient or decision to submit the manuscript for publication. 1:1 randomization with the use of web-based system with the stratification according to the participant in the site. The treatment group assessment was known to both treating physician and patient. Estimated that the sample size is 636 would be provide the trial with 80% power at the two side of alpha level 0.5. Determine the non-inferiority margin 0.8, assuming the common odds ratio for score on the modified ranking score. Effect will be correspond to difference 4% between the patient in the thrombectomy alone group, direct M80, who had MRS group ranking score was 0 to 2, range with the intervention group of Mr. Clean multi-center randomized control trial of endoscopy with acute ischemic stroke in Netherlands trial. Assumption of 5% withdrawal with a consecutive 15% reduction in sample size because the adjustment for major prognostic variables that include the age, baseline stroke severity, collateral follow, blood flow status, and time from the stroke onset randomization. Total 20 additional patients were enrolled in order to compensate those who had a major protocol violation. Setting for this study: 41 academic tertiary care centers in 18 provinces of China, selected in bias of their stroke treatment capabilities as recorded in National Prospective Database. Chinese Stroke Center required to have performed at least 30 endovascular thrombectomy procedures during the previous year. Study conducted the duration Feb 23, 2018 through July 2019. Population for this study: this is inclusion criteria, clinical diagnosis of acute ischemic stroke, occlusion on the intracranial segment of the internal cavity artery, both terminus and non-terminus occlusion, and or the first proximal second segment of the middle cerebral artery by CTA. CT or MRI ruling out the intracranial hemorrhage. Eligible for IVT or MT, mechanical thrombectomy or IV thrombectomy within 4.0 hours after symptoms onset. This is a window period. NIHS less than more than 2, age of 18 years or older, written informed consent. Information about the extent of early cerebral ischemia or baseline computed tomography as measured by Alba stroke program. Early computed tomography aspect range 0 to 10 with higher score indicated a fewer early ischemic changes was not required. Exclusion criteria: disability before the stroke defined as a score more than 2, modified ranking score, assessed by the treating physician with the use of information obtained from the patient any contraindication for IVT according to guidelines American Association. Blood pressure more than 180 by 110, blood glucose less than 2.7, or cerebral infarction in the previous 6 weeks, red severe neurological deficit or sign of recent infarction, neuroimaging, serious head trauma in the previous 3 months, major surgery or serious trauma in the previous 2 weeks, gastrointestinal or urinary tract hemorrhage in the previous 3 weeks, previous intracerebral hemorrhage, use of anticoagulant with INR exceeding 1.7, known thrombocyte count less than 100, treatment with a direct thrombin factor 10 inhibitor, treatment with heparin, ability to exceed the upper limit of normal value in previous 48 hours, baseline characteristics, median age, median NIH score, median aspect value, median time for stroke onset, and median time for randomization growing the picture. Intervention intravascular thrombectomy alone, control group, thrombolysis plus thrombectomy in 328 patients, 326 patients in intervention in only thrombectomy alone. Combined treatment with intravenous alteplase at a dose of 0.9 mg per kg body weight before the endovascular thrombectomy. The alteplase infusion could be completed during the endovascular thrombectomy. Even the procedure was successful in establishing the revascularization. Management common to both groups. Clinical assessment were performed at baseline 24 hours after the randomization, 5 to 7 days at the time of hospital discharge, whichever first came, 90 days. Outcome primary modified ranking scale score was assessed at 90 days. Thrombectomy alone was not inferior to combination of thrombectomy with alteplase. Adjusted common and adjusted. Secondary outcome, no significant difference in modified ranking score, median NIH score, Barthel index, recanalization, median lesion volume of CT in thrombectomy plus thrombolysis group significantly greater successful reperfusion before the thrombectomy, 2.4 versus 7. Safety outcome, death, asymptomatic intracranial hemorrhage, symptomatic clinical intracranial hemorrhage, infarction of new territory, large of malignant infarction, any procedural complication. Strength for this study, an independent data safety monitoring board was responsible for the safety ethics conduct oversight, use of result interim analysis, an independent control research organization, cardiovascular Chinese Research Center, and site management organization, Shanghai Tager Medical Technology were involved in the monitoring the initial trial and quality. Primary outcome was assessed per protocol. Patients who met all eligibility criteria received the assigned treatment and report had deterioration in their condition before receiving the endovascular treatment. Allocation alternate with computerized randomization, blending of the outcome assessor, only one patient lost per group. Witness authors note that validity may be impacted different stroke rate between Asian and non-Asian patients. Trial design in accordance to the AHASA guidelines. Stent retrial were recommended for thrombectomy. Intravenous thrombolysis was restricted to standard dose of alteplase. Trial did not take into account newer thrombectomy devices such as aspiration catheter or thrombotic drugs such as tenecteplase. Pre-specified non-inferior margin was generous. Sample was small. There were wide confidence intervals around the primary outcome. Possible that combined the therapy is superior. Patient consent required for payment process in China may affect time to alteplase in the combined treatment group. Patient in combined treatment group received thrombectomy only 5 minutes later than the those thrombectomy alone group. This means that this result will not apply the center that give thrombolysis prior to transferring the tertiary center of thrombectomy. Author conclusion, in a patient with acute ischemic stroke with a large vessel occlusion, endovascular thrombectomy alone was to non-inferior to thrombectomy, preceded by the alteplase administration within a window period 4.4 hours after the symptom onset, within a relative margin in the confidence interval of a 20% shift between the categories of modified ranking scale at 90 days. This is an interesting study which likely applies mainly to stroke center with the thrombectomy capability, but unclear whether the data are robust.